Chronic subdural hematoma, CSDH. Definition. Chronic subdural hematoma, CSDH, is a collection of blood and blood degradation products between the dura mater and the arachnoid layer of the meninges. It typically develops over weeks to months following minor trauma, though it may also occur spontaneously, especially in elderly individuals or those on anticoagulation therapy. Causes and risk factors. 1. Trauma. Even minor head injuries, often unnoticed or forgotten, can lead to tearing of bridging veins, which bleed slowly. 2. Age. Common in the elderly due to brain atrophy, which stretches the bridging veins, making them more susceptible to injury. 3. Coagulopathies and anticoagulant use. Use of blood-thinning medications like warfarin, aspirin, or direct oral anticoagulants increases bleeding risk. 4. Chronic alcohol use leads to brain atrophy and coagulopathy. 5. Other medical conditions, hemodialysis, low cerebrospinal fluid pressure, intracranial hypotension. 6. No apparent cause. In some cases, no specific trigger can be identified. Pathophysiology. Initial bleed, tearing of bridging veins results in venous bleeding. Formation of membranes. Over time, granulation tissue forms around the hematoma, producing inflammatory mediators. Rebleeding and expansion. The outer membrane may produce new capillaries, which are prone to rupture, causing recurrent bleeding and hematoma enlargement. Symptoms. Symptoms develop gradually due to the slow expansion of the hematoma and the brain's ability to compensate for the increasing pressure. Common signs include 1. Neurological symptoms, headache, persistent, worsening, progressive cognitive decline, e.g., confusion, memory loss, weakness or paralysis on one side of the body, hemiparesis, slurred speech or difficulty speaking. 2. Behavioral changes, personality changes, apathy or lethargy. 3. Balance issues, unsteady gait, falls. 4. Seizures, less common. 5. Visual disturbances, rare. In severe cases, patients may present with reduced consciousness or even coma. Diagnosis. 1. Clinical history and examination. Focus on head trauma history, medication use, and progressive neurological deficits. 2. Imaging. CT scan, primary diagnostic tool, shows a crescent-shaped hypodense, chronic, or isodense lesion over the brain's surface. MRI, more sensitive in some cases, especially for smaller or atypical hematomas. 3. Differential diagnosis, stroke, brain tumors, meningitis, or other intracranial pathologies. Treatment. Treatment depends on the size, symptoms, and progression of the hematoma. 1. Conservative management. Small, asymptomatic hematomas may be monitored with serial imaging. Medical management. Management includes discontinuation or adjustment of anticoagulant medications, control of comorbidities like hypertension. Anti-inflammatory medications like corticosteroids may be trialed, but evidence is mixed. 2. Surgical intervention required for symptomatic or large hematomas. Procedures: burr hole evacuation. A hole is drilled into the skull to drain the hematoma. Craniotomy, a larger opening in the skull to remove the hematoma and associated membranes. Postoperative care involves monitoring for recurrence, infection, and neurological improvement. Prognosis. Good prognosis. Many patients experience full or significant recovery, especially if treated promptly. Risk of recurrence. Recurrence occurs in 10 to 20% of cases, often requiring repeat surgery. Delayed diagnosis can lead to permanent neurological deficits or death if untreated. Prevention. 1. Minimizing fall risk. Use assistive devices. Ensure safe home environments for the elderly. 2. Medication management. Regular review of anticoagulant and antiplatelet therapy. 3. Alcohol moderation. Reduce alcohol consumption to prevent atrophy and coagulopathy. Chronic subdural hematoma, though potentially serious, is often treatable with timely diagnosis and intervention. Regular follow-up and addressing underlying risk factors are critical to reducing recurrence and improving outcomes.